Thank you. Thank you for that quick pause. And also thank you to our sponsors, ASI, Ipsen, Merck, and Pfizer. Those are all great videos. And I would like to welcome Dr. Kristen McAlpine, who is very generously donated her time today and expertise. But I also wanted to thank Kristen because you are bringing to us today an excellent and important education tool on a new treatment in kidney cancer. And you have been the lead author on this decision aid, and that has also been a gift of your time and expertise, and we truly appreciate it. And I want to mention to our patient community, because they're very popular, Kristen was also the lead author on both Ottawa decision aids in surgery and should I have surgery, and treating my small tumor. So those have become one of our most valuable education tools at Kidney Cancer Canada. So thank you for all of it. And I'll let you take it away. Thank you so much. I should actually give you a little bit of.
Oh, no, it's
sorry.
Okay. Don't worry. Don't worry. I'll introduce myself. No problem.
Okay.
Thank you very much for
Thank
having
you.
me. And I won't take up the whole time. So you'll get yourself back on track. Yeah, thank you very much for the opportunity to speak today. I'll just bring up my slides. All right, so here we go. I'm not on mute. Everything looks good. Okay. So thank you, Christine, for the invitation to be here today. It's always really nice to be able to interact with our patient community and to have this opportunity. So my name is Kristen McAlpine. I'm a urologic oncologist. I work out of Credit Valley, which is in Mississauga, Ontario, which is just about 30 minutes west of Toronto for anyone that's out of the province. And today I'm going to talk about the development and acceptability testing of a patient decision aid to support the decision of adjuvant pembrolizumab in patients with high-risk kidney cancer. So as we know, many patients, when they're first seen by their family doctor or eventually a urologist, are found to have a large kidney tumor. And these patients can go on to have a removal of their entire kidney called a nephrectomy, or removal of part of the kidney that has the tumor called a partial nephrectomy. And this is often done when there's no spread of the tumor outside of the kidney. However, when those tumors are growing into the fat outside of the kidney or into blood vessels around the kidney or into other organs, about 50% of these patients with locally advanced kidney cancer will recur within 5 years. Now, there have been many, many studies that have looked at different types of drugs to see if we give them after surgery for high-risk patients, can we decrease the risk of kidney cancer coming back and increase the likelihood of someone surviving. And unfortunately, these have largely been negative, where we have not been able to do that. There was one study that showed that we could decrease the risk of kidney cancer coming back, but those patients had a lot of side effects, and in the end, it did not increase their overall survival rate. However, very excitingly, in the last couple of years, there have been 2 publications about one study called Keynote 564, which provided a new option of pembrolizumab, which was an immunotherapy after surgery for these high-risk patients. So here's the inclusion criteria. I'm sure you've reviewed this earlier in the meeting, but Keynote 564 included patients who were over the age of 18 years old. They had had a partial or radical nephrectomy with negative margins, and they had to have been within 12 weeks of their surgery to be randomized. They had to have clear cell renal cell carcinoma and be deemed high risk of recurrence. So what that meant is either they had a T2 tumor, which is a larger tumor, and it was either aggressive or had some aggressive features. It was a large tumor that was growing into the fat outside of the kidney or into the blood vessels or another organ. There was kidney cancer in one of the lymph nodes near the kidney that was removed during the surgery. Or there was one or more sites of disease, of metastatic disease that was removed with the surgery or in a subsequent surgery within 1 year, and there was no evidence of disease. Patients could not have had previous treatments, either oral pills or IV medications for kidney cancer. And patients who were included in the study received either pembrolizumab or placebo intravenous every 3 weeks for up to 17 cycles, which is about 1 year. So these are the graphs that show the results of this study. And actually, these are likely to be updated very soon. There's been some hints that at a big meeting called GU ASCO in the upcoming months, there will be updated data from this study, which is very exciting. So this graph looks at the likelihood of kidney cancer coming back over time. And essentially what it's showing is with the blue line, these are patients that got the pembrolizumab. Patients were less likely to have kidney cancer come back if they received the medication. This graph, similarly, the patients who got the pembrolizumab are the blue line, and this is looking at overall survival. And although the patients that got the pembrolizumab, it looked like they're doing a little bit better, it hasn't been run for long enough, meaning that there haven't been enough patients that have had the outcomes of interest for them to say whether this was going to be a successful trial or not. And that being said, the hints that we've been getting through some of the researchers on these studies are that in the next few months, we'll have updated data here to suggest that overall survival is better with adjuvant pembrolizumab. So anytime patients receive a treatment, there is always the risk of adverse events or side effects. And pembrolizumab is no different than other medications in this category. So in this table, we can see patients that received pembrolizumab versus those that received placebo. And these are more considered serious adverse events, so bad things that occurred when the patients received the drug. And you can see that it's about double the number of patients that received pembrolizumab compared to those that received placebo. And again, for very serious ones, there was many more patients in the pembrolizumab group that had adverse side effects or negative side effects. So whenever you're looking at it, it's important to know what are those side effects. And the most common were fatigue, diarrhea, itchiness, arthralgias, which are like joint aches and pains, hypothyroidism, and rash. And many of these are treatable, and many of these, like fatigue, diarrhea, may not cause very serious outcomes for a patient, but they can really affect their quality of life. That being said, there are some side effects of immunotherapy and pembrolizumab that can really affect a patient's quality of life and their health overall. And so as an immunotherapy agent, there are the rare but possible patients that develop very serious side effects, like the development of new diabetes, the development of the adrenal gland not working, and someone needing steroids for the rest of their life. And so now we're faced with this potential option of a patient who has one of these large renal tumors. They meet with their doctor, they undergo their surgery to remove the tumor, and they qualify to receive either adjuvant pembrolizumab or no adjuvant pembrolizumab. And this is available in most provinces in Canada. And this is a challenging decision because as patients, there's a need to balance out the pros and the cons, and to think about what are the potential benefits of using this medication, but what are also some of the potential cons of using this medication. And it's a very challenging decision that requires a lot of thought and can be difficult for patients and clinicians to come to a decision in a short meeting that you might have in the clinic. And so Kidney Cancer Canada approached me with Kidney Cancer Research Network of Canada, asking if we could develop a patient decision aid to help facilitate shared decision-making for this very challenging decision. And you might say, well, why you? And the reason is that we've actually made multiple of these patient decision aids over the last probably five or 6 years that aim to help patients be informed about the decision that they have to make, They have to look at the possible outcomes and the management options, and then they can have an informed discussion with their clinician to determine what the best option is for them. So a little bit more about what a patient decision aid is. So a patient decision aid is a clinical tool that's used to facilitate shared decision-making for a specific population of patients facing a challenging decision. In order for it to be a patient decision aid, it has to explicitly state the decision that a patient needs to make. It's got to provide the management options and the various outcomes. And then it has to help clarify patients' values and preferences. Previous research on patient decision aids and all different healthcare decisions show that patients who use a patient decision aid have increased knowledge of their health condition. They have more accurate risk perception. They are more involved in the decision-making process, and in the end, they have more satisfaction with the decision that they've made. Decision aids also decrease patients' decisional conflict, which is the that feeling of indecisiveness or the battle between which option to go for. It decreases indecisiveness and the variability of care that patients receive. When patients and their clinicians come to a high quality shared decision, what's involved is patients must have the best available data. It has to be individualized approach to their data. So for example, a patient who has a large kidney tumor, but no signs of spread outside of their kidney, is different than a patient that had a large kidney tumor that was removed and one site of spread outside of their kidney. And so in order to properly inform an individual patient, it's important that we use individualized approach to their circumstance, but also to the evidence that we have from the research that we have available. It's important that we use patient-centered language, and then we assess and incorporate individual patients' values and preferences. About 5 or 6 years ago, kidney cancer researchers from across the country, as well as patient advocates, came together to develop the top 10 priorities for kidney cancer research moving forward. And one of these priorities was to develop decision-making tools for patients and healthcare providers to help guide treatment decisions in all stages of kidney cancer. And because of this call for action in this area, this is why we created the decision aid for patients with small renal masses and for patients with larger localized renal masses. And again, the creation of this current decision aid was to directly address this need for assistance in developing tools to assist shared decision-making. So the objective of our project was to develop a patient decision aid to facilitate shared decision-making for patients with advanced kidney cancer considering adjuvant pembrolizumab after kidney cancer surgery. We followed an evidence-based and systematic approach to the development of this tool, which is the same approach that we have used for all of our decision aids. The patients that were included were those that would have been eligible for the Keynote 564 study. And so again, we've talked about this, but it depends on the results of the surgery, how aggressive or advanced the tumor was. Patients had to be within 12 weeks of their surgery, and they had to be deciding between adjuvant pembrolizumab or not. The two management options are to receive pembrolizumab and monitoring, or to just receive monitoring and not to receive pembrolizumab. The benefits and risks are shown on the decision aid using figures and diagrams to better present the data. So for example, here we can see the benefit of no detectable kidney cancer after 2.5 years of follow-up, which is directly coming from that one study, Keynote 564. And you can see here that the number of shaded faces are the number of patients or the percentage of patients that you would expect to have that outcome. So for pembrolizumab, 77 out of 100 or 77% of patients based on the trial would have no evidence of kidney cancer at 2.5 years, compared to 66 patients in the no pembrolizumab group. We also included the very important risk of serious negative events or adverse effects. And again, we use diagrams to demonstrate that with pembrolizumab, you would expect more patients to have serious negative events. We did use descriptive language to highlight the most prevalent and common serious negative events. So we included diarrhea, bowel inflammation, abnormal liver tests, high blood pressure, but then also included some other serious negative events that some, but not all, would require additional medications and monitoring blood work for the rest of a patient's life, which would be like the development of diabetes, where a patient would need to take insulin and monitor their blood sugar for the rest of their life. After all the data is presented, we include a page on the decision aid that helps patients clarify their values and preferences. And what this means is after a patient's had the chance to look through their options and the various components of that management options, it's important for them to then think, well, what is the most important to me? So for example, how important is it for you to delay kidney cancer for coming back? If it's very important, a patient would check off 5 or 4 here. How important is it for you to receive every treatment possible for your cancer? Again, for some patients, that would be a 4 or 5. For some patients, it may not be, though. And so they can highlight to their clinician that might be not as important to them. In the other category, to receive monitoring with no pembrolizumab, how important is it to you to avoid multiple medical appointments and hospital visits? So as I previously mentioned, for adjuvant pembrolizumab, patients would need to come in every 3 weeks for intravenous treatments, and there would often be blood work before and after. There might be more scans. And so for some patients, the coming in for multiple medical appointments may not be a problem. And for some patients, that would be very, very challenging and not something that they would want to do. And so this process or this exercise is to help patients clarify their values and preferences before they come back to speak to their clinician. The next step on the decision aid is it's really assessing patients' knowledge based on the information that they received. And so it asks for knowledge-based questions for a clinician to then review to better understand if the patient is grasping the information in a way that they can make a properly informed decision. So just for one example, what option may decrease the chance that kidney cancer will come back within 2.5 years of follow-up? And an individual that had reviewed the decision aid could say they think it's pembrolizumab, no pembrolizumab, both options, or they're not sure. And again, this just helps a clinician understand where a patient is coming from when they're coming into a discussion. After we created this patient decision aid draft, we then went forward with what's known as acceptability testing. And what acceptability testing is it's asking stakeholders, so individuals who are highly invested in the creation of this type of tool, to review the tool that we had created and to provide feedback, both narrative feedback, as well as to answer 10 questions about whether they agree with the tool that we've created or if they think that there are areas that need to be improved. So across the development and acceptability, we had 10 patient advocates who participated and provided us feedback. We had 5 urologists, 8 medical oncologists, and 2 methodological experts. This is an example of the survey, but it was an online survey that patient advocates and the clinicians completed. So here are some of the results. So one of the questions asked, did you feel the language used was easy to follow? And the vast majority of responders did feel that the language used was easy to follow. The length of the decision aid was felt to be appropriate for the vast majority of responders, and some did feel that it was too long. And a very important question to us is, I believe this decision aid would be a useful tool for a new patient, and both clinicians and patient advocates unanimously agreed that they did feel that this would be useful for a future patient. And so this is where our decision aid is now. We've completed the decision aid, and Christine and Kidney Cancer Canada are just in the process of preparing it for being able to print, but also to put onto the various websites. So this is the front page of our decision aid, and it reads, should I receive pembrolizumab after kidney cancer surgery to prevent cancer from coming back? And there's various slides about that really explain the decision that needs to be made. So on our second page, we go through this decision aid may be for you, and it really highlights which patients would be appropriate or would be candidates to receive adjuvant pembrolizumab, so that if a patient who is not informed about this by their clinician after surgery, they might be able to see this decision aid and say, well, that seems like that could be me. And they could bring it to their clinician, and then this option could be discussed. So it's also a way to inform patients of their options, again, to unbias the treatment that they're receiving. We go on to explain, well, what is pembrolizumab? And again, it's very critical that when we use decision aids, we're using patient-friendly language. And so we want to include both terms that are understood broadly, but also some medical jargon that you might be coming across, so that patients will understand that, for example, pembrolizumab is another name for the same drug called Keytruda. And that might be very confusing when you're hearing about all these different types of options. So on our decision aid, we also try to inform patients as best as possible about the treatment that they're trying to consider. We then clarify which patients are eligible to receive pembrolizumab again. We discussed the research on pembrolizumab after kidney cancer surgery and try to simplify the language of the one important trial, which is Keynote 564. And again, this was reviewed in detail by several clinicians, but very importantly, from 10 patient advocates who provided us feedback on the wording of all of this as well. We then also talk about understanding the research on other medical treatments after kidney cancer surgery. So we review the other trials and that they weren't positive, which is why really only adjuvant pembrolizumab at this point is the only option available in Canada. We've talked about steps 2 and 3, which were clarifying the values and preferences of each individual patient, as well as those knowledge-based questions. And then in step 4, after an individual has had the chance to go through the decision aid, they can then highlight to their clinician or to themselves as well that I prefer to receive pembrolizumab and monitoring. I prefer to receive monitoring and no pembrolizumab. I need to discuss the options with my doctor and family, or I need to read more about my options. And this really helps so that when someone comes to clinic, the clinician knows where they're coming from and can help guide the time that they have available in the clinic to direct the resources that an individual might need in a very individualized approach. So where are we now? Well, once we finalize the decision aid, we will upload it on the Ottawa Decision Aid website, which you can see here. And this one was for our small renal mass one. Sorry, this is for the larger renal mass one. So it's on the Ottawa Decision Aid website, and it's freely available to anyone internationally. And then Christine and Kidney Cancer Canada are preparing the decision aid to be ready for print, but also to apply to the new resources for patients and caregivers, so that an individual will be able to access this and will be able to review the information and inform themselves of what options are available and what they might be deciding between. So in summary, we've created a novel patient decision aid for individuals on whether to receive adjuvant pembro after kidney cancer surgery or not. This tool was felt to be acceptable with stakeholders, and it was endorsed both by Kidney Cancer Canada and the Kidney Cancer Research Network of Canada. And there is a plan for international dissemination. So I'd like to say thank you very much. These are all the co-investigators that were instrumental in the initial draft of the decision aid, but also I'm sure there are many of you that are here today that helped us as patient advocates and reviewed this decision aid and provided detailed feedback, and we really, really appreciate it. These tools are meant for patients, and so they are, the whole point is that there's patient involvement during the whole process. And so thank you very much for your time. And if you do see the tool in the future and you have future feedback, please let us know, because I would always be happy to have more feedback and to update the tool to make this as best as possible for future patients. Thank you very much for your time. And if you have any questions or comments, I'd be happy to answer them now. And this is my email address if that would be an easier way to reach out to me too.
Thank you very much, Kristen. That was really informative. And I really appreciate the patient-friendly language. That makes such a difference. It was excellent. I do have a couple of questions for you, if you don't mind. And first, I wanted to say thank you so much for highlighting the importance of shared decision-making. It doesn't always happen, but we're super glad when our healthcare professionals also talk the same language and tell patients that it is important to talk to your healthcare providers, and you do have that right. So this is going to be an excellent tool to let them do that, to engage with their healthcare professional. And I really appreciated you mentioning the top 10 priorities. We don't see that as often, but it was great that you brought that into your talk. I have a couple of questions. Number one is, would this treatment, because of the timeline, would this treatment be restrictive for patients in remote and rural areas? And if so, how might they go about accessing this treatment if it's right for them?
Yeah, that's an excellent question. And it's an excellent question that also a lot of the urologists ask a very similar question when they reviewed this data as well. And the answer is that as a urologist, someone who operates on kidney cancer, it's important to know what patients are eligible for and to understand that a patient's values and preferences are of utmost importance when we're talking about the various treatment options. And so for some patients, even though they are in remote locations, it's important for them to meet with a medical oncologist to be able to discuss the treatment options. And then it's possible, sometimes, not always, that the treatment may be able to come back to a chemo chair or an infusion chair closer to home, where even though their specialist may be in a more remote location or in a more urban location, there may be an infusion chair closer to home and a clinician closer to home that can monitor for the side effects. And then it would be not as frequently that they would need to go into the main center. So it is challenging because the treatments are every 3 weeks. And so whether that means going into a more urban center every 3 weeks, or at least having an infusion chair closer to home, that is a limiting thing. It has to be done in a center that would be able to facilitate IV medications.
Okay, great. So it would be okay. I'm guessing that it would be okay for the patient to have that conversation if they are in that situation, that they're not close to necessarily a cancer center, but ask, their oncologist, is this possible for me? Is there some way that we can work this out? Don't be afraid to ask.
Yes. So importantly, actually, it's important to ask your urologist, the person who does the surgery, because what often happens is the individual will have surgery with one of us. We get the pathology report back, and the surgeon has to kind of identify that this is an individual who would be a candidate for adjuvant pembrolizumab. And so many patients, if the clinician wasn't clued in, would never go on to see a medical oncologist and then would never be considered for this. So it's actually your surgeon that you have to ask this question to after surgery. Because we act as the gatekeepers, which is why I want to, present these types of tools and have them available for patients everywhere, because we want to make sure that the treatment and the options that individuals are receiving are not biased, and that they're people have options regardless of who your surgeon is as well.
Right, that's great information. Thank you. And yes, then it is most important to talk to your urologist about this. So, and I think the key is for us to get the word out as best we can and share with as many healthcare professionals and patients. I wanted to assure you that after today, we wanted to introduce this exciting learning tool today by you, and now it will take home on our website. It is actually ready to go to print, so it will be happening next week. Will be available for our patients to email us or call in, and we're happy to send that out to them. And we are going to have it in key centers for our patients that we've already made agreement with to hand it out. But you know what? If you happen to be one of those patients in an area where you're not actually being treated in a cancer center, please reach out to us, because we're happy to send that information free of charge to that clinic or your urologist, just so we can get the word out and share with other patients. So thank you so much, Kristen, for today. I don't see that we have any other questions, but if you do, please don't hesitate to reach out to Dr. McAlpine or ourselves, and we'll make sure that she gets the question to give you the proper answer. So thank you so much for your time and for this learning tool. It's really important.
Thank you very much. Thank you for the invitation. Have a good day.
You too. Thanks.